We are honored to have distinguished faculty from Cincinnati Children's Hospital, USA, one of the world's most reputed institution in the pediatric orthopedics and trauma. So their willingness to share their knowledge and experience with us is truly valuable, and we are grateful for their time and academic contribution. So I would like to sincerely thank our organizing team and Healthcare Foundation for the supporting this initiative. Uh, with this, I extend a heartfelt welcome to all our esteemed faculty and Dr. Sheetal Parikh. So he is always ready to give a time and scientific dilemma to us. To all participants, I look forward to a highly enriching academic session. So thank you very much. So I would like to invite Dr. Sheetal Parikh for this a great academic bonanza. Thank you very much.
Thank you, Dr. Kamlesh Devmurari. It's an honor to be here, and I'm excited to be part of this program. The program is scheduled to include talks related to pediatric fracture care, including spine trauma and hand trauma. Unfortunately, both teams right now are scrubbed in cases, but hopefully they would be able to join us shortly. Kevin Little, who is a hand surgeon, he would talk on hand trauma if he gets out of the OR, and Karen or Dr. Viral Jain would talk about spine trauma if they finish their case. So we are going to start with some knee fractures, controversies around knee fractures, and see if we can learn from each other. So I'm going to start my talk. This is fractures around the knee, and our knowledge has evolved, just like Kamlesh has evolved, from his early days when he came. I first met him. That I think it's more than 10 years, probably around that time, and now at least his hair color has changed. So if we look at the fractures of the knee in children and what can go wrong, this is a study of closed claims in the Patient Compensation Association, so those cases which ended up with some lawsuits. And if you look at those cases, there were 13 cases of malpractice related to knee trauma in children, 6 cases related to missed tibial spine fractures. They get missed because it falls between pediatric trauma and sports medicine. So it's important to be aware about the diagnosis at least, so it doesn't get missed. One popliteal artery injury was missed, which was associated with a medial femoral condyle fracture, and others were cast and post-op complications. So let's just look at, we are going to cover cases and complications related to each of these areas around the knee joint. So we'll talk about some principles, and then I'll share a case to stress the importance of the principles. So as far as principles of treatment is concerned for distal femur physeal fractures, this is the Salter classification. So for Salter 1 and 2, if the fracture is undisplaced, you can cast them, but if they are displaced, then we should not only reduce it, but reduce and fix it. So close reduction is never enough when it comes to distal femur fractures. So you don't want to do close reduction and cast a patient with a displaced fracture. If you have to close reduce it, always pin it. Okay. For type 3 and 4, we have to have anatomic reduction because it's an articular injury. So we would recommend a CT scan for all intra-articular fractures around the knee as well as the ankle. Anytime you see or you suspect that there is a fracture line, get a CT scan. You'll be surprised to see that it may be displaced when it didn't show displacement on the X-ray, or may show you an extra fracture line which you did not see it on the X-ray. If it's truly not displaced, you can treat them in a cast, but if it's more than 2 millimeters gapped open, or if there is a step off, then these patients need anatomic reduction and internal fixation. Whether you open reduce it or you close reduce it and fix it, it should be anatomic reduction. If you look at the growth disturbance after distal femoral growth plate fractures, this was a study done by my partner, Dr. Melman. He showed 52% growth disturbance. That means half of these patients would have growth disturbance if they have a distal femur fracture. Now, how can we reduce that? So one is that displaced fractures have more rates of growth disturbances as expected because it's more trauma compared to undisplaced. Salter 4, which are high energy injuries, have more rates of growth disturbances than Salter 1, which is one of the most common type. 1 and 2 are more common than 3 and 4. But the important thing is that if you reduce and if you fix the fracture, then the growth disturbance rate is much lower than if you don't reduce it or you reduce it and don't fix it. Okay, so not only it's important for fracture reduction, but it is important to decrease the rate of growth disturbances. That's why you want to fix these fractures. And in spite of fixing these fractures, you still may end up with a growth arrest. So this is a 12-year-old boy. This is a typical Salter fracture. You want to make sure neurovascular examination is okay, because these patients can have neurovascular deficits, and you can treat them both ways. I usually do it in flexion, that means in supine position, but you can also put them in a prone position and reduce this like a supracondylar fracture and pin it in the same way. And the classic pinning is cross pinning, and you can go retrograde like this. You can also come antegrade, or you can go retrograde and antegrade. So one pin retrograde, one antegrade, just to keep everything on the lateral side. So this patient was treated correctly, but in spite of that had physeal arrest. You can see so much of osteopenia. You can see, but this patient wasn't infected. You can see that the physis is, you can hardly see the physis here. You got to, how do you know like how much of a growth arrest you have? And there is software in the MRI for physeal bar mapping, so you can map the physis and see how much of an area is involved. As you can see here, in this patient, we had the bone bridge and this mapping, which shows that this much percentage of the physis is involved. But do you think that you can safely excise this bar? It's unlikely that you can excise a bar this size. So then what are the options? Typically, around 30% bar excision is, you can get an acceptable result. When you push the limits, go to 40-50%, then probably you're going to, not have that great results. So in this patient, the patient had growth arrest. So what do we do? Now, there is a mild valgus deformity here. So we did a contralateral epiphysiodesis so that we don't end up with a limb length discrepancy because the patient was still growing. And you can choose the implant of your choice, whether you use percutaneous screws or you use 8 plates, or sometimes even not using any implant and just doing a permanent epiphysiodesis is good enough. You just have to go and drill into the physis, and you might not need to use any implants. So this is another case, 13-year-old boy who fell off a bike, and this is his x-ray. So let's just see, what do you think, what kind of fracture this is? You can see that there is an injury around the distal femur, correct, both on the AP and the lateral view. So we'll just start. I don't want to point out anyone, but what do you think, what kind of fracture is this? If you had to classify in a Salter fracture, what Salter classification is this fracture? Type 4. You think there is an intra-articular component, right? Is it, do you think it's the component is, so I don't think we have a pointer here. Are you seeing the extension into the articular surface on the AP or lateral view? The type 4 is intra-articular, right, by definition. So are you seeing the extension on the AP x-ray? Is that what you think it is? Or are you seeing it on the lateral x-ray? Just look at one x-ray AP. What do you see on the AP view? Do you think it's a fracture of the lateral femoral condyle? You can't make out, but you do think that there is an intra-articular fracture on the AP view. On the lateral view, do you see intra-articular fracture? On the lateral view, do you see that the physis, that the condyle is displaced? Do you think that it's displaced at the physis? But do you see any intra-articular extension? No, AP view, we have said that, okay, we see that there is a fracture line going into the joint on the AP view. What about on the lateral view? through the metaphysis. No, you're right. The Hoffa is a correct, the adult terminology, but you can call it a Hoffa type. So this is how it was treated. Closed reduction percutaneous screw fixation. We had 2 screws going like this. It looks really good on the AP view, like there is no step off or gap, and then it looks pretty acceptable on the lateral view as well. And the patient came back at 6 weeks follow-up. Now you can see that on the AP view it still looks okay, but on the lateral view, do you think that the entire distal fragment is posteriorly displaced? Would you agree with that? So then what do you think the fracture type was? And what do you think, so say for example there was an intra-articular fracture, but then the entire distal fragment has moved. So do you think it's a T fracture, like one fracture line going through the physis and then a fracture line going into the articular surface, something like that? And what would you do now at 6 weeks? Do you think that, so your intra-articular fragment is pretty good block now because there is no step off that at least I can see, but the physis is posteriorly displaced. So would you try to now do something about it, or you would accept it? Because anytime you are manipulating a physis at 6 weeks, there is more issues with growth arrest, right? Even I would say the 6 weeks is of course too long of a time, everything is healed, but even if it's 6 days, it's too late. Okay, if anything around the physis you want to manipulate, you should do it in the first maybe 4 or 5 days, max. And after that, it's you're going to have more damage rather than trying to correct it. So we let it remodel. It was of course inadequate reduction, but it was a Hoffa fracture actually. We got a CT scan, and there was a fragment. You could see that there is a coronal fracture on the lateral view, and on the X-rays you can't see this. And so it is not a true Hoffa, but there is a Hoffa component to the fracture which was through the physis. So that is why it's important to get a CT scan before you start with the treatment, right? And now you have to just wait for remodeling, and luckily this patient did not have any issues. It remodeled well, and we didn't have to do anything. But this is just as part of looking back and looking at the X-rays. You would think that if there is any suspicion of intra-articular fracture, don't just go in the OR. Get a CT scan, and you'll be surprised, about the fracture lines that you can't appreciate on the X-rays. If we look at this study, intra-articular physeal fractures of the distal femur, it's a frequently misdiagnosis. So you may be even, so one is that you miss it completely. Second is that you misdiagnose. That means you diagnose it but incorrectly. So it's important that you get a CT scan on these patients, and they had 49 patients there, and majority was Salter 3 involving the medial femoral condyle, and 39 were missed. 39% were missed, and displacement on the CT scan was twice compared to X-ray. Okay, so on the X-ray, if you think it's 1 millimeter, and you may say I may treat non-op. If it's 3 on the CT scan, you would change your management. So it's important to get a CT scan for distal femur, proximal tibia, and distal tibia intra-articular fractures. Okay, extra-articular is fine. So here is another example. 11-year-old boy had football tackle. I'm not going to quiz you on this one because it's a little bit difficult to see. But again, you can see the fragments, right? The fracture fragments on the MRI, and they said non-displaced Salter 3 fracture, and we treated it conservative, but it shows the fracture lines which were not seen on the X-rays. Here is a 9-year-old boy. He fell playing basketball. Do you see any fractures, any injuries? Okay, so there is a fracture on this side. Okay, the advantage of clinical evaluation is that you know where the swelling is, bruising is, where the pain is, so you can focus on that area. And then this patient, when the CT was done, you can see that there is a fragment there on the medial side, medial femoral condyle. Right, you can see that. And when you get the MRI, what do you see here? There is a perichondral ring injury. Okay, so look at the perichondrium on the other side, and then you compare it. You see the black line, which is continuation of the cortex of the bone from the metaphysis. Look on the medial side how that black line, that is the periosteum. It continues as a perichondrium. Okay, when it comes below the physis. And now you look on the other side what has happened. So the periosteum and perichondrium are lifted up, right? So it's a perichondrial ring injury. It is a physeal injury, but it's not described in the Salter-Harris classification. It's described in the rank type. You can call this modified Salter-Harris 6 or rank type 1, which is a perichondrial ring injury. You see it when you have open injuries and part of the physis is ablated, like in the medial malleolus after a road rash and bike injury, you would see it. But these injuries are very prone to having growth arrest, because when it's lifted off, the bone is going to form between the periosteum and the remaining bone, and that's what happened here. You see that there is a growth arrest on the medial side. And so this patient, we went in and we removed that. I don't have the x-rays. I'll put the x-rays because this was done a year ago, and the patient then did resume his growth. But we did have to go in and remove that, and we just interposed cranioplast in that area. So just this is important to know, the perichondrial ring injury. You see it around the ankle, sometimes around the knee as well. Let's look at the next type. Any questions on the distal femur physeal fractures? Yes. So this was not displaced, so I would not, it's difficult to predict, which patients are going to have growth arrest. Not everyone is going to have it. If they are significantly displaced, there are procedures, they're called the acute Langenskiol procedure, where you can fat graft a fracture. So Langenskiol described how to prevent growth arrest when the bar is excised by putting fat in that area. You can do it acute procedure. So when you're fixing, so say for example it's displaced, you go in to fix it, you can put fat in that area of the physis and then fix the injury around it. It's called an acute Langenskiol procedure. You can do that. There are some reports, early reports, that putting like fibrin glue around that area would prevent physis, and there are some, I've spoken with some physicians who have tried using it and have been successful in preventing by using some fibrin glue on the physis. But it's not, there is only one published report, and that too not in humans. So it's a little bit preliminary, but there may be ways to prevent it if we know that we are going to have issues. So one is type 4 is a rare injury, and I would not treat type 4 with pins. Okay, pins are usually the cross-pinning are for type 1 and 2. When it comes to 3 and 4, you want compression around the articular surface, right? Not just fix it to the metaphysis. So you end up putting screws, okay, not pins, unless the patient is really, small. But smaller patients luckily, they don't have that injury is uncommon. But you typically would fix the intra-articular part with screws, just like you do it at any other place. Yes, in post-op, those are growth recovery lines, so you would see it and you would follow them to make sure that the growth is okay. And you cannot just look at that they are parallel, you can also look at how much growth has been there, whether they are growing like they're supposed to grow, or whether it's a sick physis, means it would grow symmetric but at a lower rate. Okay, so you can calculate if it's 1 year, then you expect 9 millimeters from distal femur, 6 from the tibia. You can measure the distance between your physis and the Park-Harris line, and you would know what the rate of growth is. So a pre-op CT scan, here the CT scan was done post-op. So pre-op CT scan, you would know, and then it's your choice. If you have capability, I would just put a scope in to make sure it's well reduced. You can use an arthrogram. You can open it if you want. So how you treat it is not as important as maintaining the principles that you need anatomic reduction of the articular surface. It's your choice depending on how your training and what is available. You can treat it whichever you want, but you want to make sure the articular surface is restored. So the principle is anatomic reduction and internal fixation. Whether you open it, whether you do arthroscopic assisted, whether you do closed reduction, is your choice. So in this case, what I would have done if I had a CT scan and I knew what the injury was, I would fix the articular block first with screws, but the screws would be A to P, not medial to lateral, because there is half a fragment. So A to P screw, I would have fixed that. And then for that block to be fixed to the metaphysis, then you can cross pin it, just convert it to a type 1, right? Yeah. So it's a diagnosis in hindsight if you can't see it on the x-ray, but it's just that you need to be aware about it, because say for example there is tenderness around the distal femur, you don't see anything on the x-rays, there is swelling, you probably just need to get an MRI then to look at it. Now if you diagnose something and there may be other injuries associated with it, intra-articular injuries, anytime you have a traumatic knee effusion, you need an MRI. Okay, anytime. Not all traumatic knee hemarthrosis means traumatic knee effusions. You need MRI because 70 to 80% of them are going to have injuries which would need surgery. Only few times you would have just sprain of some tissue. Once you have a hemarthrosis, either you have an osteochondral fracture, you have a ligamentous injury, a meniscus tear, something going on. So anytime you have a traumatic knee effusion, you should get an MRI. No, not unless you have a growth arrest. So surgery is not required for all of these patients. It is not required. But you need to be aware about it. You need to let the family know that this has a high chance of having growth arrest, so you can follow those patients. If they have growth arrest, you'll have to treat it. You don't need to treat like undisplaced injuries or perichondral injuries if they are undisplaced to begin with. You don't need to treat them by surgery. But you need to be aware about the possibility of having growth arrest. Okay. All right. No, I will. I mean, it would take some time to get the MRI done, but I'll just order it right away. It doesn't matter whether it's day 1 or day 4 or 5. They need to get it done so that you can diagnose. If you can't see anything on the x-rays, then most likely it's a soft tissue injury. It's either ligament, meniscus, something. They all can wait for treatment, but diagnosis is important. So I would just get it on day 1 if they can do an MRI that day. But typically in your setup, it does take a few days, like 3-4 days, to get it done. But yeah, all traumatic knee effusion needs, they should get MRI. Okay, so this is an injury which you might miss if you are not used to seeing the x-rays. Clinically, if you see the patient, then the patient is going to have an extensor lag. There would be a gap. You can feel the gap below the patella. The patient cannot do a straight leg raise, and it's equivalent to an adult patellar fracture. It's a patellar sleeve fracture. You can also compare the patellar height on the other side, because when you're doing surgery, you can restore the height. A lot of times it's anatomic reduction, so you're not worried about over reducing. It's very difficult to over reduce it, but you can still get the x-ray of the other side to look at what the height should be, like this. Okay. And then there is a visual and a palpable. You can see the defect, right? On the right side, you can see that there is a defect just below the patellar, below the patella. And this is the patellar sleeve fracture. If you're in doubt, you can get an MRI. You don't need it most of the time. You know what the injury is, but it's just because the cartilage and the junction between the ligament and the cartilage in the kids is it's weaker. It just pulls the entire sleeve, including a big chunk of the articular surface. So you have periosteum from the dorsum, and you'll have the articular surface from the inside, everything pulled off as one unit, and then you go in and fix it. And there are a couple of different ways of fixing it. So one is you ignore the fragment and you do a patellar tendon repair. Okay, just like if there's an acute patellar tendon avulsion, you do transpatellar tunnels, you suture the patellar tendon and you put it in the tunnels, and it would go on to heal. The other way is to treat it as if it's a patellar fracture. You can do tension band wiring. If you think that the piece has some good quality bone in it, then you can do tension band wiring. And studies have shown that you know, this is a study of 20 patients. 7 patients had no osseous fragments, so it was just like a patellar tendon avulsion, and all had transosseous repair with the suturing of the patellar tendon and had excellent results. So patellar sleeve fracture, I mean, it's very difficult not to be able to diagnose it by pediatric trained surgeons. The adult orthopedic surgeons might miss it, but if you are aware of this injury, that this happens in kids, then you can certainly look at it. The next one is a tibial spine fracture, which is either hyperextension. So in the past, it was either because of skiing or because of bike, but now you see it in all sports. It has changed the epidemiology in the last 15, 20 years. You can see with different types of sports, you would see tibial spine fractures. It's much more common than it used to be. And it's equivalent to an adult ACL tear with a peak age of 8 to 14 years. Then the ACL stretches before the fracture, so even if you fix the fracture, you can still have a little bit of laxity in the knee, but it's not instability most of the time. So you're not worried about ACL deficiency, though there are higher rates of ACL tears in future. And this is diagnosed on a lateral X-ray. Even the classification is based on lateral X-ray. But it can go missed. Like I showed you initially, there were on the malpractice cases, 6 cases were missed tibial spine fractures. And I've treated a few of this tibial spine a year out from the injury. Because if they have multi-trauma injuries, you focus on big bone injuries. And so I've treated one who had like femur nail, tibia nail, and everything went on to heal, and the patient had knee pain and had a big piece that, if someone had looked at the knee, you could not miss it, but the focus was all on a femoral shaft fracture and the tibia shaft fracture, and so they missed the tibial spine fracture. And even at 1 year, I was able to go in. I had to just do a mini open. The problem with any fracture inside the knee, because it's in very good nutrition-rich environment, the synovium or the synovial fluid is good nutrition, the piece grows much bigger the further late you go in. So you have to trim the piece to fit into the bed. The piece keeps on growing even when it's not attached to anything. Okay, so if you have a loose osteochondral fracture piece and you go in to fix after a few months, that piece has got much bigger than where it started from. So you need to make sure that you can trim it, sculpt it well to fit it perfectly. So the classification is based on lateral X-rays, and for a type 1 which is undisplaced, you can just put them in a cast. For type 3, obviously you got to fix it if type 3 is completely displaced. Type 2 is some people would try and reduce these fractures, close reduction, by putting them in a little bit of extension and then casting them, and then some would recommend fixing it. Now, my personal opinion, I've tried to reduce type 2s and have not been very happy with the reduction most of the time. So in my practice, they end up with surgery. But you can try to reduce them and look at the fluoro, and there is controversy about whether you should hyperextend it or whether you should keep it at 0 degrees or whether you should keep it at 30 degrees, and different reasons why you should fix in each different position. And you can choose, or you can just look at the fluoro, where do you think it sits perfectly. Like hyperextension is not physiologic, so it's not very comfortable position. But theory is that the tibial plateau can push against the condyle and can reduce the fracture. Whereas if the piece is sitting good at 30 degrees, then that's a very comfortable position for the patient, and then it can keep it reduced if there is no tension on the ACL. Because as you extend, the ACL gets tension, it may just pull the piece off, whereas if you relax the ACL, it may sit well. So there are theories on both sides, how do you immobilize it. But you can check on the fluoro where the piece wants to sit, and you can do it. For me, I don't usually attempt close reduction, I fix them all. So you have 2 choices. You can either put a screw through it, you can either put a suture through it. Now the good thing about the tibial spine fractures is that if you're not trained in arthroscopic surgery, you can still treat it very well because it's anterior, right? It's just in the anterior part of the knee. So you don't need a scope. You can just open it a little bit and just retract the patellar tendon, and the piece is right there. You can just keep your finger on it and put a screw or put a suture or put an anchor, whatever way you want to fix it. So there is no reason to not treat it just because you don't have scope skills. Okay. Anything related to the posterior aspect of the knee, you do need a scope. If it's a posterior meniscus tear, if it's PCL, you need to know how to use a scope. But anything which is anterior part of the knee, like if you have a tibial spine fracture, for example, or a femoral avulsion of the PCL, that is also anterior. it's very easy to just open up a little bit and it's right there in the notch. So you can just go ahead and fix it. So if it's in the back and you don't have expertise, you can refer the patient, but don't let it go untreated. So this is, would you do a close reduction? This is a type 2. So as I said, this was early in my practice, and I tried to reduce it. You can see the cast on, see what the piece, there is no difference in the piece. I tried this on a lot of patients, early on in my career, that 20 years ago. And then I feel much more. Then if you do reduce it, you have to see them weekly, make sure it doesn't pull out again, and I just prefer to just fix them. I mean, if they are displaced, I just fix all displaced fractures. Now you can have malunion, and what happens with the malunion, like this patient did not have a reduction. So, it would, you would it would impinge in extension, right? If you have an anterior lip that's elevated, then you're going to have issues with extension. And so this patient had extension loss. So I would recommend not to let this go unreduced. There are also cases of arthropibrosis. That's the downside of doing surgery, is arthropibrosis. So a lot of people think that we should wait just like an ACL for 3-4 weeks, and a lot of people think we should treat like a fracture in the first week. And the earlier you treat, there is more rate of arthropibrosis. We compared our series. I tried to fix them in the first week, and my partner fixes them after 3 weeks. There was no difference in arthropibrosis rate in our series, between me and my partner. But you can not only get extension loss, you can get flexion loss as well. And then when you try to manipulate these fractures, for arthropibrosis, you can end up with more injuries, like here 3 distal femur fractures during manipulation. So the best thing is that you do things so that you can mobilize the patient early. That's why I don't like the close treatment. You fix them well, fix them anatomic, fix them rigid, and mobilize, maybe in 2 weeks. I give them rest for 2 weeks and mobilize them. That way you don't risk arthropibrosis, because arthropibrosis is a big concern, and it's real, and it's really difficult to treat it once it's in there. It can just, really devastating, complication. So the best way to avoid it is to fix it rigidly so you can mobilize it. The other thing I don't like it, initially, I used to put epiphyseal screws, because if you put a transphyseal screw, then you have to go back to remove it because it's going through the physis. But what used to happen with the epiphyseal screw, a lot of times they would back out because the fixation is not good enough. And here's a case where, it's fixed really good on the table. You can see on the fluoro. But if you look at the post-op, it's as good as it wasn't reduced. Okay. So, when it happened in a couple of patients, and I changed, and now I do transphyseal. I would say if I do screw, I would do transphyseal. I've changed my practice, and I've a little bit more suture-based now than screw-based, just to avoid second surgery. But this is transphyseal. I had no problems. We have looked at our patients, and we published on transphyseal screws, and no issues with growth arrest unless patient misses follow-up. Okay, if the patient doesn't come back, then you're in trouble. So you got to trust your patient. You need to explain them. If you don't come back, what kind of deformity they are going to have. You're going through the physis, and there will be change in the tibial slope depending on which way your screw is going. There is going to be deformities in both planes, coronal and sagittal plane, if they don't come back. Okay, so you need to be careful and don't want to end up with an osteotomy after tibial spine fracture. Yeah. I take them out between 3 and 4 months. Mm-hmm. So I don't think that whether you get bicortical or not, I don't think that would change anything. But if they are putting 2 screws, you have to be, really careful and check in extension that the screw head does not impinge. I've seen patients where the screw is prominent and you have a washer underneath, and then you extend and it will touch the top of the notch. Then you're not going to extend it. Then you're going to end up with arthropibrosis. I put 2 screws if the piece is big enough, and but you have to be careful. Yeah, but what I'm saying is that putting it through one thing is that if you're putting transphyseal, you'll have to remove it. To me, it doesn't matter if it's bicortical or not. Like, I usually don't go bicortical, but I don't think that would cause a problem unless your screw is pinching the vessels in the back. So if because it's right there, right? If you go too long on the screw on the AP view, you would be against the fibular neck, okay? And if you get too long on the lateral view, you'll be in the back of the knee. So you want to make sure that your screw is not long. So I don't like to go bicortical, but I don't think that if there is one or two threads, like in tibial tuberosity fractures, we frequently go bicortical. And I've not seen any issues as long as you know what you're doing. Like, you don't want to drill without control, and you don't want to plunge in the back of the knee. As long as you maintain precautions, you just need to know what is safe. So this patient, for example, if you take it out, it doesn't give you. So I remove all my screws between 3 and 4 months, just like, yeah, you have to remove it. That's why over a period of time, I've changed my practice a little bit more towards suture-based treatment, so I don't have to do second surgery. But I still like the screws when it's a big piece. I feel very confident when I put a screw, and it's so easy for me to do a screw. Like, technical ease is there, but I've shifted just a little bit to prevent a second surgery, not because of growth arrest or issues. Because I tell the family, most of our patients are very reliable, so I've not had patients who would not show up. Because 3 months is not that long of a time. Like, sometimes the patients would not show up after like epiphyseal, like guided growth, because you have to wait at least a year, or and then the patient forgets. But for this one here, you're still undergoing treatment. You're only 3 months out. You're doing physiotherapy. You're still under care. It's not completely. They're not back to sports yet. So in that case, at 3 or 4 months, I would remove it, and I've not had, and not even a single case of growth arrest with transficer screw. But it has been reported, like this patient, if they, I have some colleagues who have sent cases with growth arrest and deformities because the patient didn't come back. Okay, so like this one, you can see that, recurvatum deformity because it was, the patient never came back. And then there is a delayed ACL reconstruction in young patient with previous anterior tibial spine fractures. In this report, 19%, that's too high. Usually it's around 5 to 7% is the rate that is what I would tell the family that you needed. This is just a series. Let's just, we have spent about 30 minutes. I have, this talk I can go on for 2 hours, but in interest of time, I'll let Kevin come and talk about hand fractures if he has his stuff ready. You have a jump drive, you want to use this, or you have your laptop? Either way is fine. Okay. Yeah.
Good. Hear me okay? Online you can hear me? Good. All right, so buy my book. It's really great. I get no royalties from it. It's for the Hand Society, but it will tell you everything you need to know about pediatric hand surgery. So we talk a little bit about epidemiology of hand fractures, how I think about treating them, what my approach is to the examination, and then we identified the bad actors. I don't know of any bad Bollywood actors. Are there bad Bollywood actors too? Like, yeah. Okay. Good. You gotta clue me in on those as well. So as you know, the child uses their hand and wrist to explore the world, and as such, it's the most commonly injured part of their body. And so, a lot of ER visits and like 35% of fractures are in the hand and wrist. So these injuries generally occur at home in the beginning, around the house, even outside, indoors. Then they get to more playground sports as they get older. and then even work injuries in teenagers. Oftentimes it's, in the fingers, the border digits, the ones that stick out, especially the pinky finger. It's about half of all fractures. And there's really a bimodal distribution. Age 2 is the fingertip smashing injuries. I'm not sure who takes care of those here, but we see them like every night in our emergency room in Cincinnati, 2 or 3 of them. And then age 12 is a second peak around for sports injuries. Most of the fractures that we see are non-displaced and extraphyseal. And about 3/4 of all hand fractures really don't need to see a surgeon. They can just heal on their own, but we help guide their treatment. But we want to know who the bad actors are, right? Because Dr. Swanson, he is a great hand surgeon, but he said hand surgeons can be complicated by deformity from no treatment, stiffness from over-treatment, and both stiffness and deformity by poor treatment. So don't do that. So in general for kids, right, we're lucky that we take care of kids because they have a large soft tissue envelope, they have good blood supply for most fractures. Pretty much everything heals. You can have a lot of help with growth from for remodeling deformity. And so physeal fractures of the hand generally don't cause issues. They do in the wrist, but not in the hand. And everything tends to remodel well except for malrotation. So you have to want to check for that in all of your patients. So when I see a patient, I really look at what happened, what they did immediately afterwards, and tell me if they reduced the fracture themselves or if they had somebody pull on it, or was it ever pink or white, numb, tingly, those things, and show me where it hurts. Like point to one spot that hurts the most, because they'll tell you where it hurts, like where it's broken. Usually they say it hurts everywhere, but you kind of drill down, they can tell you. And then I always think of my sort of exam, right? Look at it first, touch it last, right? So look, inspect, look for range of motion, malrotation, and then palpate last. And they have to do special tests like Elson tests. We'll talk a little about it. You always want to get hand x-rays for metacarpal level, so 3 views. Finger x-rays, you want to get a finger x-ray for a finger problem. That's a big problem where we are, that you miss some fractures on hand x-rays that are in the fingers. And then the wrist, you always want to get an AP lateral wrist, and sometimes scaphoid views or stress views for really weird, complicated injuries. But here's an example of a fracture of the proximal phalanx. Yeah. Usually 3 views on initial, because sometimes the condylar fractures are seen best on oblique views. Our ER, if they order finger x-rays, they always order 3 views. But in general, for follow-up, you can usually just order 2. But really what you need is a good lateral of the finger. That tells you the most. So this x-ray doesn't look too bad. But then you get the finger x-ray, and it's really a displaced phalangeal neck fracture. Ends up with pins that could have been, treated poorly and been stiffness and deformed. So going through some cases that are bad fractures, this is sort of the pediatric Bennett version, where you have a physeal injury, a Salter-Harris 3 fracture. There's an articular component where the ligament attaches that remains intact, and the rest of the thumb dislocates. So it's really a fracture dislocation. That's what a Bennett fracture is. And then you have to reduce it and hold it in place. But sometimes these shift out of place over time. So generally you have to fix it. Either pin the joint together or reduce that fracture with the screw, because they do displace over time. On the opposite side of the physis, these aren't so bad. Because of remodeling and the motion at the CMC joint, you can tolerate about 45 degrees of angulation, and they can heal pretty well. But you have to either accept the deformity or treat it with pins. Like, you cannot reduce these and hold them because the thumb swelling is so bad from these fractures that it does not allow you to mold a cast. They slip out, they have problems, never stays. So really I tell patients either accept it or have surgery. But I generally accept a lot of angulation, and they do really well. The ones that are completely translated into the web space or something, then I'll try to reduce those. This is a kid that had a pretty benign looking fracture on x-ray, but the soft tissue was bad. So tried to blow off his thumbs with a homemade balm. But surprisingly, despite all of that, healed perfectly well and had pretty good function. He lost some adductor strength because he ripped those apart, but other than that, was quite successful in healing, just getting those fractures to heal with no growth arrest. You know, blow the physis apart, it still grows. So other metacarpals, there's no physis. For the finger metacarpals, you don't have to worry quite as much. There's joints do not move very much, so you don't have to worry too much about them. The biggest risk is crush injuries and compartment syndrome. And then fracture dislocations in older kids at the CMC joint of the fourth and fifth metacarpals, from punching injuries or bad biking injuries where you hit the ground. You have to watch for the dislocation there. So this is a patient that came to my office, fortunately about 24 hours out from injury, had a large TV fall on their hand, and had non-displaced fractures, but had compartment syndrome because of all the swelling. You can see the soft tissue swelling. They healed without any surgery. They did compartment releases, sewed them back up 2 days later, and fully healed without any kind of surgical treatment of the fractures. We treated the compartment syndrome, that the fractures were stable. It wasn't an unstable fracture, it was just a crush injury causing swelling. A little bit more distal, the shaft. Yes, Preek? Yeah. Mm-hmm. Usually all of them. So what I tend to do is a thenar release, a carpal tunnel release, a hypothenar release, and then the dorsal. And if they're really mobile skin, you can make one incision and then move the skin to release all the compartments between each metacarpal. So the second, third, and fourth web spaces. And then you just open up the fascia between them. No, I generally do everything, a carpal tunnel release included, because there's so much swelling globally. So even if you have metacarpal fractures on the small side of the hand, you usually do a thenar release anyway, just to make sure, because it can get worse over time. You don't want to miss something. Ask the med student, Eugene, how many compartments are in the hand? Uh-huh. Cool. It's a lucky number, or an unlucky number. Yeah, Kamlesh. Mm-hmm. Yeah, I put a slab typically. If the fractures are really unstable, I'll put pins in, but I don't put an X-fix. I don't think you need that much. If it was a bad distal radius, then maybe to hold it to length, but that's not a problem. Usually K-wires are sufficient, or intermetacarpal screws. We can talk about that a little bit with this picture, but yeah, so put screws in generally helps pretty well, but K-wires are your friend. Even with really bad fracture dislocations of the CMC joints, you can put lots of K-wires in. That stabilizes the soft tissues and then allows you to manage the compartment wounds and then heal the fractures. So in the shaft of the metacarpals, there is malrotation and shortening. So malrotation can cause problems with rotation. Shortening can cause extensor lag. Not so bad in younger kids, but it can be in older kids, young adults. And so these are the patients that you want to fix if they're having those issues with that. If they're skeletally mature, you can do metacarpal screws like this one, except this patient went back to playing basketball and broke his screws, so big problem. Neck fractures are a different problem. There is no accepted angulation limit. I have a patient with a 90-degree malunited fracture, distal, and he came in because the deformity was there and someone told him he had to get it fixed, and his full motion, no pain. Why fix it, right? It doesn't matter the degree, it matters the function. So you have to watch their function. We generally cast them because they're not trustworthy, but beyond that, there's lots of data suggesting buddy tape is as good as reduction in terms of outcomes. So we just kind of treat them for comfort, whichever is the easiest. But they do happen again because they don't learn to stop fighting and punching things. I'm not sure if that happens here in India as much as America. Lots of people get mad and fight when they're young teenage boys. The only thing that you sometimes see with a significant malunion where it's really flexed down is that it causes the MCP joint to hyperextend and you get a pseudo-clawing deformity. They can't flex down anymore around the metacarpal, so they get stuck in a hyperextension, and then they have a lag at the PIP joint, and that can cause problems. You have to fix that with an osteotomy of the metacarpal, and then the pseudo-clawing improves because they can flex around it again, and it helps get the angulation fixed up. The most common fracture we see are these physeal or extraphyseal juxtaphyseal fractures. We call it extra octave fracture, so you can reach the piano and get an extra key or two. Quite benign fractures, they heal really well. My general acceptable alignment is 15 degrees or less, but if they have good ability to adduct their fingers and flex without malrotation, you can accept anything that looks like a normal hand. We treat hands, not x-rays. So if the hand looks good and the x-ray looks bad, as long as it's going to function well, you can treat that benign and it will heal itself. So if they're really angulated or malrotated, I generally reduce it under local in the clinic. You can flex the joint down and put the finger where it needs to be, and buddy tape. If you buddy tape any finger to the middle finger, it will stay. Except the middle finger, you have to tape it to something else. So the pinky finger, you tape to the middle finger, it won't move. If you tape it to the ring finger, it moves side to side. But tape it to the middle finger, it's very stable. And then index finger, middle finger, except the thumb. You can't really tape the thumb to the middle finger. But 3-finger tape, yeah, for pinky finger fractures. 3-finger tape, very stable, won't move. These are trickier fractures. These are articular avulsion fractures. If they're reasonably well aligned, they can heal, but there can be a large chondral component. And if they're unstable, because it's a ligament avulsion, then you should fix them. So a patient like this, you pin it together, it fixes. It does pretty well. Either reduce it closed and pin it, or open reduce it. If it's a small piece, sometimes you have to do something like this, where you put a suture anchor in and then tie it down with a suture anchor. And that works really well. Base of the middle finger fractures can be problematic, especially for these that are dorsal lip fractures. If it involves a significant portion of the dorsum, the joint will subluxate volarly and then cause big problems because the central slip is attached. You see little tiny flecks of epiphysis sometimes on fractures. That's really a capsular avulsion fracture. If it's a big piece into the metaphysis, then it's a central slip fracture. And those need to be treated either with very close monitoring or an extension splinting and casting, or AF if they're unstable. So a fracture like this needs to be fixed. Volar plate avulsions are generally not so bad unless it's a big component or if the joint starts to subluxate. So a volar plate fracture like this tends to heal very quickly just by early motion protocol, no casting, maybe buddy tape to prevent it from being injured too much. But you can have a pay like this. This is actually one of cricket players in Cincinnati, a young cricket player, catching a ball, get the finger jammed. And if you see this dorsal V sign here, that sign is that the joint is subluxating and it's actually articulating with the fracture fragment because the volar lip has been sheared off. And those need to be fixed with early treatment. So that got fixed with a few screws, and he healed well. Early motion, got back to cricket very quickly. So we have the same thing in the U.S. that you have here, the cricket fractures. Phalangeal shaft fractures that are like this are typically unstable, oblique, long oblique fractures with displacement and malrotation. Those need to be fixed because there's no way to hold them still. Yep. Yeah, with pins or yeah, you can. I do that a lot actually with some of the base fractures. If it's a fracture at the base of the proximal phalanx near the growth plate and really out of place, it's hard to put a pin retrograde to hold it, so I go antegrade. With oblique fractures like this, it's a little bit trickier, but you can go kind of out each way and pull it out. So if you do that, you kind of pull it out all the way and then have the pin sticking out distally. Yeah, and people are starting to use headless compression screws in these types of fractures too, because they tend to hold it pretty well. You need small screws though. Talked about phalangeal neck fractures a little bit. These distal fractures are the head where the joint is, and so you have this lip of bone that blocks flexion. it can be problematic because they lose motion, and so those you generally fix. But if they're minimally displaced and don't look too bad, and they can flex around it if they're just angulate a little bit, so the Al-Katan classification will tell you like if it's really out of place or not. So if it's not too out of place, they actually do remodel and heal pretty well. But this malrotation that you see like this, that doesn't heal, so it has to be reduced and casted. Remodeling can happen, so a fracture like this that shows up a month later that's healed and really crooked, you can watch that over time. You know, that Bach defection that you have will remodel, and my colleague Dr. Cornwall has shown this over 6 months to 2 years. You can see full and complete remodeling of a phalangeal neck malunion. It's far from the physis, so it takes a long time, but it can happen. And so knowing this, I'm able to treat some patients without surgery that could have, you know, had surgery if they don't want it. I give patients a choice, like, do you want me to fix it now, or would you rather not have surgery and wait a couple years to get the motion back? And as long as they understand the risks of both, I think there's no wrong answer for them. But if they are starting to heal and they have these issues, there's a technique called osteoclasis, where you break up the healing fracture, healing callus with a K-wire and lever it back into place and then pin it. So a fracture like the one I showed you before tends to heal reasonably well with osteoclasis. You can get it lined up, get rid of that block to motion that you see here, and get it to line up back to normal so it bends again. Maybe not quite all the way back to full length, but the motion will be good at the end. So phalangeal head fractures or interarticular fractures, these are problematic ones because they tend to make the joint subluxate and cause lots of problems. So if it's anything more than a crack and non-displaced, you probably have to fix it, prevent it from getting worse. I like to use a little tenaculum to reduce it. Then I like 3 K wires because 2 K wires, if one falls out, then you're in trouble. But if you have 3 K wires, if one falls out, you're not in trouble. So I learned that from experience. So and then you can see weird fracture patterns like this, where like a shear fracture coronally, where you have to reduce it to get the finger to flex around the fracture, and then I pin from volar to dorsal, kind of pulling it out to make it heal. But you do have to make sure that these are aligned perfectly. This was treated by a colleague who did not really align the fracture, didn't see the joint, and the patient lost motion. If you can see, this looks like a normal joint, but it's actually rotated about 90 degrees, and so it's not rotating correctly. So opening the joint, we found it with some displacement of the articular surface, but we were able to reduce it and anatomically realign the fracture, and then get them moving quickly. Lastly, some of the things we see are these complicated, complex hand trauma that you probably see results of as well. People have had bad injuries, crushing injuries from sugarcane juicers, stuff like that will cause big problems. And so for those, we generally explore, wash it out, and then fix. We fix the bones first, tendon second, neurovascular structures third, skin last, kind of that order. Lots of K-wires and whatever you have to do to fix and hold things, and they tend to heal pretty well. Sometimes you can be surprised. You might need to fix everything. You might not know what you're going to get. So a fracture like this looks not salvageable. Take it to the OR, wash it out, clean it up, put some pins in, and you can keep it alive. So some things you want to throw in the bucket right away, you can actually keep. Unfortunately, the patient didn't like this finger that wasn't very useful, so we took it off a year later. So even though you tell them, probably the best thing to do is get rid of it, they have this emotional attachment to their finger and have to take a while to get to the point where they don't like it anymore. So these are my thoughts about pediatric hand fractures. There's certainly some bad actors that you have to realize what they are and treat them, and recognize that they're good fractures that heal quite well, and you don't have to worry about them too much. So I'm happy to answer any questions. So please question things. Yeah. But there's a, you know, a, mm, yeah. Mm. There's certainly a big push in us. Yeah. It's sports, right? There's a huge push in our kids to play sports all the time. Play the same sport year round, or play 3 sports year round. Mm-hmm. Yeah, that's good. Your kids, your kids go to school and learn. They don't go to school to play sports. So yeah. We, we kind of try for every kid, but sometimes it's just too small. You I mean, 2 to 3 probably try. But there's one I just did recently, but just wasn't able to be replanted. We just try and seed, and we end up 2 hours later, it's not possible, so we amputate. But sometimes I've done where I've replanted and tried it and just left it on for, pinned it for a few days and see what happens and hope for the best. But there's no distal, it's somewhat of a size. A 2-year-old DIP joint, there's no suture small enough to fix the artery to make it work. Or the type of injury, if it's a big crush avulsion, it's almost impossible to fix without vein grafts for the arteries and leeches for the veins, and so it's a lot of issues. So, but yeah, it's a lot more trouble than it's worth sometimes to do. No, I know people who did them, but in kids there's a different calculus because it's the whole immunosuppression is bad. If you have a previous kidney transplant or something, then so the kid in the U.S. who got bilateral hand transplants had a kidney transplant beforehand from his sepsis. So it was a huge step to get to immunosuppression for hand transplants. So it made it easier to make that decision. But it is pretty, it's a thought process. So in the right patients, yeah, it's a good thing to do. But it has to be a lot of thought and a lot of planning for it to work. All right, thank you. I think now we have our colleagues from the spine world to give some spine trauma talk. So.
Karen, I can, barely hear you. So hold on, I think there may be some setting.
Can you see my slides?
I can see your slide, yes. So so we can hear you, but it's not, it's very low. Is there a way to increase your volume on the computer, on your computer?
We're trying. We're trying.
We can see your screen well. We can see your slides well. It's just the volume.
Okay. Sleeping now? Can you hear me better?
another option.
Can you hear me?
Okay,
Can you
बंद
hear
कर
me?
दिया तो मैं already
Hello?
Karen, can you speak something?
Listen to him.
Can you hear me?
It worked for you in the car.
Devin, can you hear me?
Can you hear me?
Why is the audio off here? There.
Hello?
ऑडियो तो बंद कर.
Can you hear us? Are we having
Can you hear me?
okay. Yes, we can hear you.
Can you hear me, Karen?
Yes.
Okay. I think you can
Okay.
carry on.
Can
You can carry on. So go ahead with your presentation.
Okay, Parikh, sorry, we have to do this in the car where everyone is leaving. I'm sorry. I'm gonna get my talking support. Stop. Okay, I have to stop. Here. Okay. I have to stop. I know. Just turn it off.
Okay. I saw Viol is there. I'll just call him. He can figure it out. Okay, we'll wait for a couple of minutes. Otherwise, we can end the meeting. It's already 7. Okay. Okay. Okay, we can record the spine lecture later on, and we can share it with everyone. Um, Unfortunately, they were able to connect. I think we were able to see the slides, but there was some volume issue. So we'll move on. We have another talk on the very common and controversial supracondylar humerus fractures. So staying out of trouble starts with evaluation. You need to always document the nerve function. And sometimes in acute setting, when the patient presents, it might be difficult to document it because the patient is crying and is in pain and difficult to evaluate. But you still want to document, or at least try to see if you can elicit some of the nerve function, because post-op, if they have any nerve issue, you don't know whether the surgery caused it or whether it was pre-existing. So it's really important to take a little bit of time to document, and just don't document using neurovascular examination is normal. You need to document everything that is important individually. Okay, so AIN, median nerve, radial nerve, and the ulnar nerve, you need to document each nerve, because AIN is the most common palsy that would see with supracondylar. And sometimes if you have median nerve issues, you can have a silent compartment syndrome and you can miss it. So unless you evaluate each and every component of it, you might end up in trouble. So I would recommend that you document nerve function, individual nerve function. When it comes to sensory innervation, we don't use this, but there is a sweat pattern that is dictated by intact sensory nerves. So if you have wrinkles after submerging for a few minutes, it's based on an intact sensory nerve. And for example, if you don't get the wrinkling, then that nerve is involved. So that's one way of knowing. In kids, because the kids are not going to complain or be compliant with whether they can feel it or whether they have tingling or numbness or weakness or pain. For them, it's all the same. They're just crying. So it's difficult to evaluate. And this one of the ways is to look at the sensory innervation. You can always document perfusion. Capillary refill time is usually less than 2 seconds. The hand has to be pink. That means it's perfused. If it's white, it's an emergency. Pulseless supracondylar is not an emergency all the time. If the perfusion is intact, then it's a pink pulseless hand. But if it's a white hand, if you lose perfusion, that's an emergency. And then you need to be a little bit more aggressive with treatment. I personally use the Doppler, the handheld Doppler, to document pulses in patients with absent pulses. But there are different ways. A lot of people use the oximetry. Some use a color Doppler flow to look at the perfusion. But basically, you want to make sure that the perfusion is intact. Pucker sign is a sign when you get the metaphyseal spike through the brachialis, and you see this. And it is not a sign suggesting that it's emergent, but you don't need to be careful because the skin can undergo necrosis if it's puckered like this. Or it also suggests high energy injury, so it might be associated with neurovascular involvement, and you may expect more swelling, more issues if you just leave it like this. You can get what is called the brachialis sign, which is ecchymosis when it in the fragment is through the brachialis and you have the ecchymosis here. Floating elbow used to be like an emergency, that if you have floating elbow, you need to go and pin both of them. You need to be wake up in the middle of the night. But recent evidence suggests that it's not as bad as you would think it was when looked at more than if I remember, there are more than 50 patients, and then none of them had a compartment syndrome. None of them had any vascular issues. So it is still a serious injury, because when you think of having a floating elbow, that means having a wrist injury and an elbow injury. You expect that everything in between is also injured. It's a continuation. But you can also have two isolated injuries. If you had a fall, like in a way that both your wrist and your elbow were hurt, maybe the middle part in between was normal. And if it's a buccal fracture, undisplaced fracture, you don't need to pin it. So it's not like everything needs to be treated. Of course, whatever is displaced, you need to reduce and pin. But you need to be aware about floating elbow because of concerns for compartment syndrome and other complications. Open fractures, fortunately, these are not common, but when they are present, you need to be concerned about vascular injuries, neurovascular injuries. They are a red flag. And almost all open fracture supracondylar look like this. Okay, So I was presenting once, and this was my patient, and Crawford said, "Hey, you stole my slide. This is my patient." I said, "No, this is my patient. Your slide is next coming up," because they all look the same. You just, you feel like this is my patient, and these are as there are associated injuries, and surgical management is important. Compartment syndrome. This patient came to my clinic like this, and so much of swelling, and his arm is thinner than his forearm, which is like reverse if you look at it. And luckily he had a lot of swelling, but luckily he didn't have compartment syndrome. But you need to be careful. What are the factors that can lead to compartment syndrome? Is vascular injury, time to reduction, excessive manipulation of the fracture, floating elbows, open fractures. And in kids, they don't present with the classic, 5 Ps that you see in adults. It is 3 As, is agitation, apprehension, anxiety, and more need for analgesic medication. You also need to be silent compartment syndrome. If they have high median nerve injury, that means the sensation is gone. So you can have a compartment syndrome and the patient may still not have pain because there is no sensation. So you need to have that suspicion, especially with a brachial artery involvement. Brachial artery, median nerve travel together, so you can suspect a median nerve injury and a silent compartment syndrome. So you need to be careful. You need to evaluate, your forearm for the swelling, as well as how tense the swelling is, and not miss it. Because if you have a missed compartment syndrome, whether it's silent or symptomatic, end result is going to be the same, VIC, which you don't want. So that is something that you need to be aware of. This is one of my patient. It very ugly scar, had a skin grafting after fasciotomy that had done. Ugly scar, but he is fully functional, good strength, works well, and he's very happy. So don't worry about long incisions. If you have to do a fasciotomy, make sure it's a wide incision. You open up everything, whatever is involved. Like I've seen someone trying to do a small, like a very small incision and then trying to do fasciotomy. Is different when it comes to an acute compartment syndrome versus a chronic compartment syndrome. Chronic is exertional compartment syndrome. So that is because the muscle and the fascia is too tight. You can make a small incision and release it. It's seen in lower legs. But if you have an acute compartment syndrome, the skin needs to be released, not just the fascia. Okay, the skin itself is also a barrier to swelling. So you can't do a small incision and then do PERC fasciotomies. It would not work. It can work in chronic compartment syndrome, but for acute, you need to open up the skin as well. So big incision and open up all the fascias. So that is how you would stay out of trouble. Now, timing-wise, does shorter time to treatment impact the outcomes? So the U.S. news in the U.S., we have a 18 hours cutoff because that's how we are judged, based on the reports that the hospital creates. And if someone doesn't, if we have a low rate of meeting this criteria, then you get dinged for it. Your rating drops. But there is not enough evidence, about this 18 hours cutoff. Obviously in a type 2 supracondylar, you can wait much longer and not have issues, but they are still counted, within that 18 hours. Now, what are the red flags and what is urgent? So if you have this patient, for example, has a vascular issue and pulseless, and you're in a center where you don't have backup and you want to transfer it, what is a good position to transfer? Certainly not this position. You don't want to keep it extended with the nerve and the vessels draping over your metaphyseal fragment. The best way to transfer the patient is to keep it in a little bit of flexion so that things can relax. You don't need to reduce the fracture, but it needs to be flexed enough like this so that, and then you can splint it. The best thing you can do is to make sure that before you see one of these injuries, you have partnership with a vascular surgeon wherever you are. And if you don't have a vascular surgeon nearby, then just be prepared to transfer the patient urgently, whether it's 2 hours or 3 hours away. You need to just have some kind of team, where you can call and get the patient treated. Because the last thing you want in the middle of the night, a pulseless supracondylar coming to your clinic, and you don't know who is the person you need to call. You need to, and if you're taking pediatric call, this is the first thing you want to do is make arrangements of transfer if you don't have vascular support nearby. And vascular injury, of course, a white hand, you need to transfer. If you have high median nerve injury, leading to a silent compartment syndrome, you might want to transfer. But if you have pink perfused hand and pulse on Doppler, we reduce these patients, we pin him, we admit them for 24 to 48 hours observation. but there is controversy about which patients need to be opened or have vascular repairs. Decision-making process is important, as long as the fracture and line, the anterior humeral line is intersecting the capitulum. I think you're in a good position on the sagittal view and Bauman's angle. So these two things is what matters: Bauman's angle on the AP view and an anterior humeral line on the lateral. There are a lot of other ways of measuring the reduction, but if you just remember these two things, Bauman's angle and the anterior humeral line, then that's it. That's all you want to restore. You're not really worried about little bit of rotation, little bit of translation. You are worried about the angulation. You don't want to end up with a cubitus varus, and you don't want to end up with an extension deformity. So just make sure that those two measurements you do on all the patients. I mean, whatever measurements you do, your Bauman's angle you need to decide, but frequently we are not matching when we are reducing these fractures. We are not matching like Bauman's angle. We are just getting anatomic fixation, so it needs to be well reduced. But for a particular injury, if you have loss of Bauman's angle, that is when you go into cubitus varus. And I've seen a lot of pinned supracondylar elbows which have either lost some reduction, and then you need to figure out whether it's lost enough that you need to revise it, or you can still accept it. So that is when you can take a comparative X-ray, measure it, and look at it. But it's variable, Bauman's angle, in everyone. In girls have a little bit higher, yeah. So it doesn't matter as long as you stick to one way of measuring it. It's your way. Okay, so you just stick to. It doesn't matter. Like you have a complementary angle, right? When you have, sometimes you measure like anything that you measure. The inverse of that is also the same measurement, except that you're looking at it from the other way. It's a complementary thing. So it doesn't matter whether you. Ideally, they report the Bauman's angle as like 74, 75, so in that range. But even if you say that, oh, my Bauman's angle I measured, it was 15 degrees, I know what you mean. It's a complementary angle, but it's still, the same thing. So Garland type 1, it's the line still touches the capitulum. This is Garland type 2. Would you leave this and would it remodel? It would remodel if it's just a pure sagittal plane deformity and your AP is, you don't have cubitus varus. This would remodel, but it is. In our practice, I don't like to take a chance. In very young patients, you can, but I'm a little bit more aggressive just because you don't want to end up with treating a malunion. So this is a type 2 fracture, and you can see that on the medial side there is collapse. The lateral side there is opening. Whenever you see an opening on the lateral side, that means that the fracture is in varus. So on a type 2 fracture on the lateral view, you may think that I can accept it, but then you look at the AP view and what you see is that is combination on the medial side, opening or a gap on the lateral side, which means that your fracture is in varus. Okay, so you can't accept this. Okay, you have to fix it, otherwise this would go into clinically it will go into varus. Anytime you see an opening or a gap on the lateral side, that means that there is the fracture is in varus. So look at this patient, ended up with a cubitus varus because it wasn't treated. They treated it conservative, thinking that, oh, it's minimally displaced, but and then this doesn't remodel, right? You don't remodel in the coronal plane. So the factors associated with successful close reduction immobilization, and then we looked at our series, do they all need pinning, whether you can just reduce these fractures and put them in a cast. And we found that, yes, 70 to 75% of the time, you can get away without pinning a type 2 supracondylar. You can reduce it and keep them, in a 90 degree, 80 to 90 degree cast, and you'll be okay. So that means that you are probably unnecessarily pinning this 70 to 75% of the patients. But on the flip side, if you think about it, the other 20 or 25% patients, you have to have a close follow up on those, because they are the ones who might need more stuff. That means they might need another reduction. They might have might need pinning. So type 2 fracture is controversial. Type 1, everyone is going to treat it conservative, and type 3, everyone is going to operate. Type 2 is controversial. My recommendation is to pin it, but I don't have any objection to someone who wants to try close reduction. In Europe, the practice is close reduction and casting. In US, it's mainly close reduction and pinning. There are regional differences, and it's not one is right or wrong. It's how, what the culture is, what you can accept, whether you're willing to, get the patient in your clinic every week for an X-ray for the first 3 weeks. And if there is a malunion, you'll have to correct it versus pin it right away. So this is a type 2 patient was pinned. This is a type 3. Usually say type 2 you put 2 pins, type 3 pins. We prefer to do lateral pinning, divergent or parallel. And in this patient at 3 weeks the pins were pulled. Now pitfalls of pin placement. Pinning is not, all pins are not similar. This patient had this pinning done at somewhere else, but you can see the pin is not even going through the fracture site in spite of having 2 pins. So if the pins are too close together, if they are crossing at the fracture site, you may have residual instability. So before you leave the operating room, make sure that after you pin it, you stress it a little bit, and then the fracture is, reduced and it's stable. Otherwise, it's going to fall apart later on, and that is even a bigger issue, because then you have to revise it, and most of the time you don't want to revise your own surgery, so it's better to just treat it right. And the reason this happens is if you have it's okay to have the fracture not reduced when it comes to rotation, but when it comes to malrotation, you have these 2 pillars and you rotate the fracture, and now you are just balancing yourself not on the pillars but on the central thin piece of bone. So unless it is fixed rigidly, what is going to happen is it's going to fall, because now you don't have the support of the pillars if there is malrotation. So malrotation is acceptable if your pin fixation is rigid. Then malrotation is acceptable. But if you have a malrotation and your pin spread is not adequate, your pin placement is not ideal, then that's going to fall apart. So, when you say that we can accept 30 to 40 degrees of malrotation, yes, you can accept it, provided you pin it and you check and make sure that it is stable. Okay? Because a malreduced fracture has a higher tendency to fall apart than a fracture that's anatomically reduced. But the reason that you need to know how much you can accept is because you don't want to end up, opening all these fractures for anatomic reduction. If you know what to accept, then you would, you'll be able to treat most of these fractures closed. Okay, you can accept translation in all views. So you can accept translation on AP and lateral view. You can accept rotation 30 to 40 degrees. That's a lot of rotation. So you might see a spike. It is okay as long as the 2 things are maintained: anterior humeral line touching the capitulum and a Bauman's angle. If you have those 2, then other things are okay. But make sure that you pin them in a way that it's stable, that once you are pinned and once you're out of the OR, it should not fall after that, because then you'll have to go back. Okay, so be careful about it. You can get pin track infection, though. These pins, the supracondylar pins are typically for 3 or 4 weeks, so it's not, the pin track infection is not that big of an issue, but it can happen. So here is a 5-year-old boy who had a foot injury, supracondylar fracture, underwent close reduction and pinning. This is a 4-week follow-up, and the pins were infected. You can see that there is, some, granulation tissue. The patient was staying in a basement, had some mold in the basement, and it's, some fungal stuff going on. And what happened is when I went to remove these pins, here is the infection. I removed the pins. There was still infection, so I tried to clean up the pus. There was pus in the joint, and the capitulum fell off. Here's the capitulum. It just fell off like, it was dead. It was just floating in pus. So this patient, from here, there was no capitulum after I was done. And this is a 1-year follow-up, and the patient at that time did well. And then the patient came back 10 years later for a wrist injury. Okay, so for this wrist injury, and had no issues with the elbow. So 10 years after taking out the capitulum, the patient is still doing okay. So it's overrated, I think. What about a type 4 fracture? So type 4 is when it's unstable both in flexion and extension. So that, people have tried to figure out, how can you diagnose a type 4 based on an X-ray, pre-op X-ray? It's difficult, right? Because unless you have an X-ray both in flexion and extension, you don't know it's type 4. So it's not a pre-op decision. It's not a pre-op diagnosis. It's an intra-op diagnosis. You try to reduce it, and if it goes into flexion, it's type 4. There are markers of what can be type 4. A lot of flexion injuries are type 4. A lot of significantly displaced, they say 300% displaced. That means, like, if you calculate the width, and if it's 3 widths apart, then most likely all periosteum is torn, and it's going to be type 4. The reason it's important is because, when you are reducing a type 3 fracture, you're taking, advantage of the intact posterior periosteum to reduce your fracture. And if you have a type 4, you don't have that intact posterior periosteum. That means when you flex it, like you are taught to flex it and pin it, when you flex it, it will go into flexion. So then you have to make sure, how do you reduce it? The way to reduce it is, keep it at 90 degrees. We keep a roll or something here. I do the pinning in a lateral view, and you can adjust on a sagittal view, you can adjust, exactly where you want. And then you can pin it with the arm at 90, because otherwise a flexion type supracondylar, you need to extend it to reduce it. And, in a type 4, if you extend it, it will go in further extension. Then how do you keep a proper balance? Is, you can keep it at 80, 90 degrees. Use this as a lever arm to, get your piece up or down. Check the lateral view. As I said, the C arm needs to be in a lateral position. You don't rotate the arm, otherwise it's very unstable. So you keep your arm in one position, and then I just pin on a lateral view. I don't even look at an AP when I'm pinning a supracondylar in a lateral view for extremely unstable fractures. Because AP you cannot miss. There is only one way to go. You just go oblique, you're going to hit the other cortex, right? At least so tentative pinning you can just do on a lateral view, and then definitive pinning, once you get your reduction and it's a little bit stable, then you can take an AP view and then put your regular pins, and you can remove the previous pin if it's not in a good position. But it's very difficult to miss your pin on an AP view because it's just oblique. You just go oblique and you're going to cross the fracture. But on a lateral view, you want to make sure that it's well reduced, the type 4 fracture. And so it's just a technical tip, because we don't open the fracture. And then a lot of people say that, it's because of experience. It's not a technical experience. It's an experience of what you can accept. It's not like our reduction is better than others' reduction. We all do the same thing. But our rate of opening a supracondylar is less than 1%. I don't remember last time I opened, and we treat like more than 200 supracondylar a year. So, but we hardly ever have to open them because we can accept a little bit of malreduction. That's the reason, not because we get anatomic reduction all the time. So flexion type ulnar nerve, you always want to check because that's the most common nerve to be involved in a flexion type supracondylar. And then you need to make sure if the reduction is adequate. So some translation okay, some rotation okay, some medial gap okay, but a lateral gap is never okay. You don't need to fix butterfly or comminuted pieces. As long as you fix the main piece to the shaft, you can ignore the comminuted or butterfly pieces when it comes to supracondylar. And it's okay only if the fracture is stabilized adequately. Okay, so this is an example of a patient who had an inadequate reduction, but only on the sagittal view. So you can see the remodeling, what happens. They are going to have, it is going to come back into position over a period of time, only if the issue is on a sagittal view. If it's falling into varus would not remodel at all, okay, in kids, because this is not a growing end, and it's not in line of your movement or your muscle forces. So anytime it's a coronal issue, it would not remodel. If it's sagittal, it would remodel because it's in plane of motion. Here is an example of someone. You can see that this is not acceptable, right? The pinning. It's a high supracondylar, difficult to pin. It has a tendency to fall into varus. But you look at this patient, so it healed in a little bit of extension, right? The anterior humeral line is not touching the capitulum here, but this is a difficult fracture to treat. And look at what happens 3 years, 4 years, and the patient doesn't have any problems. So high supracondylar, if you have a high supracondylar, the best thing to do is to do cross pinning, okay? Because if you do lateral pinning in a high supracondylar, very likely one of the pin is going to be intramedullary. You won't be able to get to the other side of the cortex. And then if you have something like that where one pin is intramedullary, it is going to fall into varus, because just imagine that you have a high supracondylar and you put a lateral pin and it is trying to get into the medullary canal. If it goes into the medullary canal, it's going to push the piece into varus. Okay, so do cross spinning when it's a high supracondylar. That's a safe way of trying to get your stability. For the sagittal plane, if the kids are less than 5 years, you'll get 100% remodeling. If they are more than 8 years, there is minimal remodeling. So just based on age, very young patient, sagittal plane remodeling is very, very dependable. But when they come to 7, 8 years, which is a higher age for supracondylar, because typical age is 4 to 6 years. But when they are going into 7 and 8 years, a little bit less remodeling. So just keep that in mind. How about this? So you have this fragment. This is my partner's case, Chuck's case. So you see that fragment that's floating, right? The butterfly fragment. And you see what happens over a period of time to that piece. So it's 4 weeks, 6 weeks, 6 months. That piece now is stuck to the shaft, right? That butterfly fragment. And then you have 1 year, and you have 2 years, and you don't see that piece anymore, right? The piece got stuck, gradually remodeled. So in sagittal plane, you don't need to fix those butterfly fragments or free-floating fragments. They would remodel over a period of time. Okay. Here is a patient with a translation. Okay, you can see that it's translated, but the Bauman's angle is maintained. Here is at 3 weeks, at 6 weeks, 6 months, 1 year, and it's restored. So remodeling is, translation would remodel very well, but cubitus varus would not remodel. So technical tips of a 5-year-old boy, we saw this case, pucker signs. So how to reduce it is a milking maneuver. You can grab your brachialis, you can pull it up and out of it, and you just start proximal and go distal, and suddenly you'll feel that small, pop that when the fragment comes out of the brachialis. And I have a video of that. You can see that there is a sign, and you just milk. It's called the milking maneuver. It's still there, and you just try and pull the muscle out, and you would feel it reduce. So now it's gone. See the pucker sign? So you don't have a pucker anymore. So it's just trying to lift and just milk from proximal to distal. Intrafocal K-wire is a useful way of reducing your fracture. So this fracture, I was not able to reduce it on table, but you can put a K-wire from the back, just in the middle from the triceps, go into the fracture site, and then you can lever the piece in position. So another trick without opening the fracture is that you can use K-wires. You can either joystick them, that means you put it in the distal fragment and get the distal fragment where you want, then put a provisional pin, and then you can do a definitive fixation, or you can do an intrafocal K-wire as well. Posteromedial versus posterolateral. Posterolateral are always more unstable than posteromedial. So when you're looking at a pre-op x-ray, just look at the direction, which way the distal fragment is going. If it's posterolateral, expect more instability. And if I know that it's unstable, as I said, I would do it with the C-arm in a lateral position, not rotating after reducing, I would not rotate the forearm, but I would just keep it steady, and I will rotate the C-arm. So this is posterolateral. This is the trick that I was telling you. It's published. How to take care of the flexion type, or even difficult, posterolateral unstable fractures, is the push-pull technique, and that you put a roll so that way you can push your distal fragment in extension or flexion by using the forearm as a lever. And I pin on the lateral view. This is the lateral view, and you see, I'm pointing this arrow to the bump that I use to put underneath the arm. And sometimes you have extreme instability, like this 7-year-old girl. What type it is? If you look at the intraop, like you see AP of the metaphysis and a lateral of the epiphysis, like almost 90 degrees rotated. That's a lot of instability, right? And so it sometimes is difficult, and you might have to do open reduction if you can't get it. This was one of the patients that I had to do open reduction in my first 5 years of practice. these are other ways, like if you open it, you can then control it well. This is the steps of open reduction. Well, it depends where the metaphyseal spike is. That's usually where I would open it. Then I can just clear it and get the distal fragment to come to that piece. And there's I've heard some surgeons routinely open supracondyls, and I don't think that is required. Cross pinning, you got to be careful about the ulnar nerve on the medial side. So there are ways of avoiding the ulnar nerve. So I typically, if I have to do it, I would just make sure that it's in a little bit of extension. I put my finger and then make a nick. I put my guide as well, or you can just oscillate your K-wire, not just go on forward, so you don't get the nerve. Relative extension, palpate for the ulnar nerve, because sometimes the ulnar nerve can sublux and come anteriorly. So you palpate it, and I do it over the medial epicondyle. I do open up a little bit and use a drill guide oscillating mode. And now the organ spin, I won't go into details, but it was a pin that was introduced that you put from the lateral side going medially, so you don't have to put a medial pin, but that has issues as well. So you can see this is how the organ spin is done. So instead of going from the medial side to avoid the ulnar nerve, you come from the lateral side and go down, so like this. It can achieve the same purpose as a medial pin can, but then you can get in trouble with another nerve, which is the radial nerve that is on that lateral side. And here is a case where the radial nerve was trapped, and this is Dr. Cornwall's photograph or slide that he had sent. The patient was operated by one of my other partners, and you can see the pin around the radial nerve. This is an open fracture, absent pulses, white hand, and I had to call Kevin for this. And this is him doing the surgery for the bypass surgery using a saphenous vein graft. So you do tend to have, but we are lucky that we have plastic surgeons, we have vascular surgeons in our hospital all the time. So that's something which we are very fortunate. So. And this was in the middle of the night. They're using the microscope to do the revascularization. Okay, I'll stop here for the sake. We have some cases, but I think we already spent 30 minutes. Any questions? So I mean, it's not like you have to open a flexion type. If you can't get reduction, then yes, you need to open it. But as I said, the trick is I showed you the push-pull technique. So if you know some maneuvers how to reduce the fracture, then you don't need to open. I've not opened any flexion type. So if they have a nerve involvement, it's not an indication to open and check the nerve, right? Most of the time when you have a supracondylar fracture and a nerve involvement, the nerve is neuropraxis, a stretch of the nerve, not a transaction. So the treatment for a supracondylar fracture with nerve involvement is to fix the fracture, and the nerve is most likely going to come back, right, in a few months. So it doesn't matter what nerve is involved, whether it's AIN, whether it's ulnar nerve. We don't look at the nerve, we just fix the supracondylar the way you would fix any fracture even without a nerve injury, and then you wait. The problem is that if you did not have an ulnar nerve palsy, you put a pin in, now you have ulnar nerve palsy. Now that's an indication to explore that you may have done damage. Okay. But if you didn't have it, if you have it pre-op, I'm not really, bothered about, the nerve getting trapped or the nerve, I know it's because of neuropraxia. I would still pin it the way I would pin any supracondylar fracture, and I will let the family know that it should come back within a few months. If not, then we have to explore, but the chances that you have to explore is very, very minimal. Well, sometimes the fracture configuration is such, like one indication I told you is a high supracondylar fracture. Medial pinning would help, and then there is a classification based on the fracture line on the coronal view. Okay, your Gartland classification is on the lateral view, but there's another classification if it's oblique in a way that that if you put a lateral pin, it's going to be along the fracture line. Then you may have to put a medial pin to be orthogonal to the fracture. So there are few indications, but not a whole lot. But you need to know how to do a medial pin if needed. But not in every case. Like people say that that's more stable than doing lateral pins. You don't need that much stability. You need enough stability to keep the fracture secure. You're going to put a cast after that. So, biomechanically, even if it's more stable, it is not safe for me, or generally, most of the surgeons just do lateral pinning just to be on the safer side. No, we use general anesthesia. Like, I don't remember a block on any of our trauma patients. We use general anesthesia throughout, for kids. I'm surprised that we are doing surgeries here in the spinal. I've not seen a spinal at my hospital ever. Unless you're talking about adolescent patients, that's another issue. But for kids, for supracondylar, I don't think that anyone would do a block at my hospital. They're all general anesthesia. Now, the depth depends on, if you think it's significantly displaced, you can let them know that you need relaxation. But they're all general anesthesia. Yeah. Yeah, there were a lot of, I've read about different types of things that you can do, but for trauma, I think you don't need to do a block. The other thing is that, with general anesthesia, you can watch for compartment syndrome or for neurovascular. Once you give a block, then it's difficult to watch for any of those complications. So for trauma, usually we don't like to do blocks because then you can mask, anything that's evolving. Any other questions? All right, I think we should. Okay.
Fold down while playing. Okay, what are the options? Close, reduction and cast, both nailing, one bowl nailing, plating or X-fix. So anyone? Given a trial of close reduction and cast. Another? Both bone nailing. Okay. Okay, so the interesting is this case actually underwent more than all these options. Let's see. Okay, it's not about what can be done, but what something failed and why finally worked. So this is a post-op day open reduction, but surgeons get difficulty to get a close reduction. So they opened it and fixed with ulnar nailing, and there is a cross K wire of radius. So any comment? It's a first post-op day. So what about the reduction quality? Reduction is fine. Everything is okay. Yes, good. Wow. So one thing is radius might get unstable. Okay, fine. That's a good observation. Why? Why it like that? Okay, good, fine. So, okay, fine. So what this is after 1 month post op. Now the comment. Okay. So was this fixation choice was acceptable? Okay. So what went wrong? What could have been done differently? You are absolutely right because it's not stable in rotation. So radius is a moving bone, ulnar is a stable bone. So it is not stable in rotation, stable in not length also and not in angulation. So biology is good, but problem is in mechanical. It is not good stable. So now your case. What is your revision plan? How you revise this case? Osteoclysis, okay. Stable fixation. Which kind of fixation? What you will do? It's your case after 1 month. Put a tense nail of ulna or radius. It's very difficult because, yeah, longer K wire, and again you go for a close K wiring for fixation. Well molded cast, but you can see there is a radial shortening. Okay. Okay, so now we want more stability, otherwise it will. So this was done. Revision surgery is a post-op X-ray. There was a dorsal plating because surgeon has opened the first surgery on a dorsal approach. So they used a dorsal plate because yes, one thing is that the radial length is not maintained. But what about the reduction quality and the fixation method? There is a dorsal plate, recon plate, ulna is same. See what we believe that in pediatric everything is remodel. It's yes, because revision says we have to take care of that. Yes, that's good. So what turns? You see this one. So this is 3 months post op. Okay, the revision is not just put a one metal. So radius dorsal plating, radius plate takes abnormal load that leads fatigue failure. This plate, it's a 2.7 plate metatarsal plate, and it is not a, it's a weaker in bending in torsion than LCP. It's not a good choice of implant. And another you nicely noted because reduction quality, reduction length is not maintained. And another, if you put a dorsal plate, a radial bow, that is very essential for the rotation. That's not a good choice of implant. Okay, so now what you will do? Now again it's your case. Now we'll ask to Sital bhai. Sital bhai, હવે શું કરશું? So it's a post 3 months, and the two open surgeries. One is K wire, another is a dorsal plating, and this is the 3 months post op. The deformity, the rotational malalignment. Now, how will you handle this case? Okay. 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 Yes, ulna is healed. Ulna is healed. There is no infection. Metabolic workup has been done, and the all reports are normal. It's a purely it's a mechanical failure. Hmm. So now what? It's a 2.7 plate. So yes, fine. So same thing. As Idalva mentioned, it's a mechanically repeated instability. Yes, biology that definitely there are multiple surgeries, sclerosed bone, and there is a functional problem. Radial bow is not maintained. So we address stability, we address biology, we protected it. So this is the power of images. We remove the plate from the same dorsal approach. It's very difficult to remove from another approach. We use the dorsal approach. Then we use X fix because radial length is very important to maintain the length. And so we created that gap. We take a graft there. We take a iliac crest graft, and we achieve the length. This is the lateral view, and we put a plate. That's a DCP locking plate. So and that we maintain the X fix to protect that. So this is immediate post-op. Okay, so plate fixation, adequate length, restore the length and alignment, grafted to offload the plate because it's very I don't know, this is third surgery if it is failed, so we kept that X-fix in situ for 3 weeks. So what again there is one problem. So after 15 days the loosening of proximal pin, so we revised the pin and we continued. This is 1.5 months follow-up, and this is after 3 months follow-up, radiological union, restoration of alignment and radial length. So what we learn, pediatric age does not guarantee union if stability is inadequate. So stability, biological and protection is very important. Because there are so many mechanical forces and I just use 3 screws there. So I am not happy that okay, if I will get a proper hold. So I want to protect, to bypass the hose muscle pull. So that's why I kept X-fix continue. I want just 3 or 4 weeks. Even though see after 15 days again the proximal pin is loosened. So you can see that a lot of forces are there. I think we have to protect this child more 1 year. I don't know. Another case. Male 10 year history of fall down. What you do? Close reduction, cast, nail, open reduction, X-fix, others. Close reduction, cast. Shalin. Close reduction, cast. Okay. कोई हम nail नहीं करे? Okay. Unfortunately, it was nailed. Okay. Any comment of nailing? It's a square nail. The radius and ulna square nail. You guys mostly don't know, but we used to do that square nail. Sidalbhai, in USA also there are no square available. Na? You do only tens if it is required. Tens nail. Okay. So closed and nailing was done. This is 1 month follow-up. Everything is okay. So this is 3 months post-op. Okay, that looks like by entry has taken. Yes, that's why it looks like that. Okay, fine. But this is the presentation. So on the middle finger, there is a non-healing ulcer of the tip of middle finger. There is loss of sensation, distal fillings of middle finger after 3 months. So how will you manage this one? Any clue? Why it happens? There is no other complaint. Fracture is united, but this is the thing. Okay, let's see. So we did a NCV, nerve conduction velocity test. We did MRI, and there was a kinking and stretching of median nerve at the level of fracture site of radius. Okay, so this is called callus entrapment of median nerve. So what is overlooked? The history was like that. The post-operatively there is a significant pain, and there was a numbness of median territory, stretching pain, that was there. And once surgeon has a nailing done, then that we will wait for that. It might be neuropraxia, it might be neuropraxia, and it will recover. So, but we have to watchful that whenever symptom persists beyond expected period of neuropraxia, then we have to take care. So why there is delay? Because patient will change the consultant now, and there is a delay. So any radiological evidence, now you can see here there is a bony irregularity, or you can see the bony canal of that part, that at that time, and you can see the callus entrapment of that nerve. So we open it, we explore. Now you can see that the whole median nerve is entrapped in the callus. Okay, so that we have excised that part, because you can't release that, it's a healed callus, so you have to just excise that part, and we did a end-to-end repair. Okay, so the ulcer healed within 3 months. So very important thing, we do a close nailing. What we do, once with the nail is outside, and we try to reduce it, and that will take the nerve. So we research so many, find so many articles that even though you do a close reduction and cast, there are high chance of median of entrapment. So what is the reason for that? Because we find so many articles, even there is a buttress torus fracture or highly 10-degree angulation, and you give a cast, and you will find a median of entrapment. Okay, so that is a entrap. Examination. Yes. Yes. Sure that. Treatment. Okay, so last case. So 11-year girl fall down while playing, fresh injury, no associate injury. And what are the management option? Okay, what you do? Close cast, close with metazu, close in K wires, open reduction fixation, any more? Metazu. Okay. Intrafocal pinning. Do metazu. Close reduction and cast. Okay, fine. So it is very difficult to get, surgeon think that, so you can't get in a close. So surgeon think that we'll open reduction. So open reduction, metazu and fixation with this intermedullary nail. Any comment of? It is reduced. It is reduced. It is reduced. Fracture is reduced. Okay, let's see what happened. Okay, there are good study, 52 studies with total 2420 children. All treatment are compared with this study. Very good, interesting. Severe angulation, more than 60-degree angulation, the open reduction showed range of motion loss over half of the cases. Okay, even intermediary nail or cross K wire, there is a chance of loss of reduction. So this is 15 days post-op. This is 1 month post-op, and this is 1.5 month post-op. So this is the presentation. Okay, so pain, stiffness. Now how will you manage this case? Sidharvai, comments. Now how will you manage? Okay. Hmm. 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 Okay. Okay. Removal of the nail, then. Yes. So there was no infection, and so what we did. So now the problem is it's a non-union, stiff elbow. There are changes of myositis and implant migration. So we have to handle 4 situations. So there are articles, 7 case in all Peter Waters article. They mentioned that inadequate fixation technique in severe displacement. There are the 2 major cause. And another, as Sitalbhai mentioned, that it's a precarious retrograde blood supply. So once you open it, then there are rate of complications are very high. So this was the presentation. Okay, so what we did, same Sitalbhai suggested, we did a spongioplasty, we minimal lateral approach, we open the defect, just we open like open book, we maintain the surrounding tissue, and they create the gap. We take a graft from the iliac crest, the exit shape of the 1 centimeter size, and we fix it with K wires, and we fixed with the headless screw. Okay. So, any comment, Sital bhai? No, that's a pure cancellous graft. So here one part there is a cartilage part of radial head, distally there is a radial neck. In between I put a spongy cancellous chuck of that 1 centimeter diameter. Okay, fine. So this is immediate post-op. Unfortunately, I broke the K wire, but the fixation was stable, so I just leave it that K wire. So this is a immediate post-op, and this is 15 days, and this is 1 month post-op, and this is 3 month post-op. So fracture is united, and you can see the range of motion now. It's still in a fissure, I know that, but quite improved range of motion. Okay, so non radial neck fracture is rare, but when there is a present that reflects compromised biology and inadequate stability. So severely displaced fractures require careful judgment. It's very important. Metasio is a effective technique, but when biology is preserved, that's why it works. And when you open reduction and inadequate fixation are the most important fracture for non-union. So thank you very much, Sital Bhai. And now I would like to invite our secretary, Dr. Abhijit Salunke. Closing remarks.
So thanks to Sheetal sir, team Cincinnati, Dr. Kevin. So it was amazing pediatric orthopedics. You covered hand, spine, we missed something. But small complaint to the organizer, they didn't cover tumors. So I'm practicing orthopedic oncology. So you neglect always tumors. Amresh sir. So next time you should consider it. So small complaint against the organizer. So it was amazing event. So thanks to Dr. Kevin, Sheetal sir. So we'd like to have more of your interaction in orthopedics and orthopedic pediatric orthopedics. So we are organizing a conference, national conference this year end in Ahmedabad. So it will be IOCON 2026. So Dr. Kamlesh is one of the chief organizers of that. So we'd like to invite you for that event also. So thanks to the audience, because until 8 o'clock you are sitting the amazing lectures. So thank you very much. Thanks. So we'll just like to symbol of New Ahmedabad. Dr. Kevin sir. So I request Dr. Kamlesh to. This is a new bridge, which is a walking bridge in Ahmedabad. Just you can connect the two parts of the city.